I am Dr. Tania Lira, working as a registered Department of Clinical Oncology, Delta Hospital Limited. I feel honored to present my study in this prestigious platform. My study title is a comparative study between delineation of two target volumes for patients with postoperative glioblastoma multiformis. Background of my studies: glioblastoma multiforme is the most common malignant primary tumor of the central nervous system. The incidence of GBM ranges from 0.59 to 5 per 1 lakh persons. The current standard treatment program for newly diagnosed GBM involves surgical resection to an extent that is feasible, followed by radiotherapy with concurrent temozolomide, followed by adjuvant temozolomide. The image fusion pre- and postoperative MRI with planning CT images is normally used to determine the radiotherapy treatment volume. The optimal treatment volume for GBM remains controversial. For example, RTOG uses a two-phase clinical target volume margin, where in phase 1, peritumoral edema plus 2 centimeter margin is used. In phase B, there is boost volume delineated by residual tumor plus surgical cavity plus 2.5 centimeter margin, whereas EORTC and University of Texas MD Anderson delineated single phase CTV margin with T1 MRI plus 2 centimeter, which involves surgical cavity and residual tumor. Rationale: the use of this limited margin RT can significantly decrease the volume of normal brain tissue that is irradiated without significant increase in the risk of marginal recurrences. The volume of irradiated brain is believed to be an important factor in the development of radiographic and pathologic surrogates for neurotoxicity. When CTV include peritumoral edema with additional 2 to 2.5 centimeter margin, RT field will be larger, which is not beneficial, because in almost all tumor recurrences occur within 2 centimeter margin of the resection cavity or residual tumor after radiotherapy. The objective of my study is to compare the outcome of radiotherapy between usage of target volumes with peritumoral edema and target volume without peritumoral edema. Also to compare response rate and toxicity of radiation between two arms. It is a quasi-experimental, non-randomized prospective study conducted in National Institute of Cancer Research and Hospital from 1st January to 31st December 2020. Total number of patients was 60, in arm A 30 and arm B 30 patients. Sampling technique was purposive sampling technique. Inclusion criteria: patients age 18 years and above, but not more than 70 years. Karnofsky performance status were 70 and more. Histologically diagnosed case of GBM, MRI proven residual disease after surgery. Exclusion criteria were patients who were previously treated with brain radiotherapy, recurrent tumor, other major vital organ dysfunction, and patients participating in any other trial. Radiotherapy technique was 3-dimensional conformal radiotherapy. In arm A, CTB were delineated in 2 phases. In first phase, postoperative peritumoral edema on FLAIR or T2 weighted MRI plus 2 to 2.5 centimeter margin. In second phase, T1 hyperintensity MRI plus 2.5 centimeter margin. And in arm B, there is a single phase CTV with postoperative residual tumor and cavity volumes on CT or T1 weighted MRI plus 2 to 2.5 centimeter margin. In both cases, 0.3 to 0.5 centimeter margin PTV were taken. Both arms received concurrent temozolomide during the radiotherapy and adjuvant temozolomide every 28 days schedule for 6 cycles. Patients were evaluated before, during, and after radiotherapy by taking history, physical examination, and relevant investigations. Here comes observation and results. Maximum patients were Mean age were arm A and arm B, 52 years. There was male predominance in both arms. There is clinical manifestation among the respondents. Karnofsky performance status of maximum patient were 70 and some are 80. Clinical response observed after 6 weeks of concurrent chemoradiation according to RECIST criteria. There is almost similar clinical response in arm A and arm B, which is not statistically significant. Then again, clinical response assessed after 6 months of completion of concurrent chemoradiation. There is also no statistically significant differences in between two arms. But in terms of overall toxicity profile, like nausea, vomiting, headache, vertigo, there is significant reduction in arm B in comparative to arm A. Other toxicities like skin reaction, anemia, neutropenia, altered level of consciousness, loss of memory, which are also reduced in arm B but statistically not significant. So, my study concluded that response of radiotherapy using target volume without peritumoral edema is similar, but toxicity is less in comparison to radiotherapy using target volume with peritumoral edema for treatment of postoperative glioblastoma multiforme. So, radiotherapy target volume without peritumoral edema can be chosen to treat postoperative glioblastoma multiforme. Thank you.